So, I have treated autoimmune epilepsy with steroids. I started off by saying we have 3 epileptologists, a 4th one coming in the beginning of 2018. The one that's coming in 2018 does treat epilepsy with IVIG and immunomodulators that aren't just known autoimmune epilepsies. So he's bringing that to our practice. I only use IVIG and immunomodulators for known autoimmune epilepsy. So we will be adding that to our practice, but through him.
What would be a reason for, like, so our kiddo has the genetic epilepsy, and then all of a sudden had
epileptic
encephalopathy, and they hit him with high dose steroids for 2 weeks, and 2 weeks, 15 days, and we're still tapering off because, and it like worked.
Stopped it.
Like he went 48 hours without a seizure for the first time since we learned that he had seizures.
And I don't know how they're using the term epileptic encephalopathy. That's the other problem. I have hundreds of people with epileptic encephalopathy. All that means is somebody with bad epilepsy who's also severely developmentally delayed with a bad epilepsy condition. So like my children with, Dravet syndrome have bad genetic epilepsy who are severely delayed, they can be termed epileptic encephalopathy.
So our son has the KCTD7 gene mutation, and we were treating him with copious amounts of drugs. And then all of a sudden he had like this pretty swift neurologic decline that our closest hospital was like, oh, it's part of his condition, put him on hospice care, sent him home. UCSF was like, no, just bring him down because we are followed by them. Took him up to the machine. He was having near continuous frontal lobe spikes, and which was different from his previous EEGs. And so they were like, no, this is epileptic encephalopathy.
So they're calling it more like an ESCS, continuous spike and slow wave sleep.
Yeah.
Okay, something more like that. Okay, I got that. I get you now. I don't have the best answer for you, but later this afternoon, I think Dr. Matt Lawless, is giving a talk on ESCS and immunotherapy, or immunomodulation. I'm not exactly sure of the title, but he might be a good person to listen to. He might have more information on it. Like I said, I wanted to kind of build an outline for future talks. That might be a good talk for you to go to as far as a direction. He might be able to provide more insight. So I know that people do use steroids for that. They do use stuff like high-dose Valium for that type of condition, high-dose benzodiazepines.
It's on feed.
Yeah, so it used to be Valium, and now it's probably more likely people are using high-dose Onfi and stuff like that. Some people use high-dose Depakote, but he might be a good talk to go to for more information. But in that case, I understand where they were using the term epileptic encephalopathy. A little different than how I first interpreted the question. So I understand.
Trying to Google it.
Yeah, so there's kind of epileptic encephalopathy as a static condition.
Yeah.
Kind of you're at a baseline epileptic encephalopathy. You were talking about an acute.
Yeah.
Okay, got it. Yeah, so I think it's Matt Lawless who's giving that talk. I think in the last hour, if you're still here. But yeah.
Okay, thank you.
All right.
After the first one, he was sleeping with them like a lot of kids do. They were terrified. Took medication every day, and then December 12th, 2009, his parents found him, bottom bunk. He had passed away while he was sleeping after a seizure. So when Danny died, the term SUDEP was totally foreign to his mom and dad. They had never heard of that risk before, and they learned about it from their medical examiner. So now our goal as a foundation is to obviously raise collective awareness around epilepsy, but also the risks that come with it, and specifically the risk of SUDEP. So Danny drives us to do that. So what we created, what his parents created, is the Danny Did Foundation. And the name of the foundation comes from the last line of his obituary, which my brother wrote, and that read, "Please go and enjoy your life, Danny did." And the idea is to embrace each day and to kind of mirror his joy for life and take a tragic situation and try to make something good out of it, which is difficult, but it's kind of our way to honor him. So that's what we're doing. So kind of the primary focus for us is to advocate for open and honest dialogue between doctors and parents, or doctors and adult patients, to share all the risks that come with epilepsy. So the risk around bathing, swimming, driving if a child is old enough, the risks of head trauma, things that a lot of us have heard about from doctors, but also to talk about the risk for SUDEP. And it's not to say that we're asking them to isolate it or to call it, to call it into its own conversation necessarily, but to not leave it out of the conversation. Because when that happens, there's a blind spot, and we can't do anything as parents to try to minimize the risk because we don't know about it. So that's what we advocate for, to kind of couch it within that risk for all the risks that come with epilepsy. So SUDEP is the most common cause of death for people with epilepsy, per the National Institutes of Health. So it's a considerable risk, and obviously the fact that there's fatality, there's really no more risk serious than that for people who are either dealing with epilepsy themselves or have kids with epilepsy. So we make an analogy, when a person is diagnosed with cancer or diabetes, they have a conversation at some point with their doctor that says, here's the whole range of what could happen, here's the spectrum of possibility, and that's what we're asking for within epilepsy, is that you have that conversation that talks about all the possible outcomes, and then we as parents can say, okay, now I really want to hone in on this one and tell me more about this, but to be educated at kind of a high level, to become aware, and then to go from there. So the risk of sudden death. And some of this I might be more scripted with, just because I want to make sure we share all the information. But we get a common question: what is SUDEP? What exactly is it? It's an acronym for sudden unexpected death in epilepsy. SUDEP is not a cause of death, but rather a category of death. A death is referred to as SUDEP when a seemingly healthy person with epilepsy dies unexpectedly and no clear reason for the death can be determined. In most cases, an autopsy is required to rule out other causes of death, and there's a set of criteria that indicate whether it's a case of SUDEP or not. One, the person has epilepsy. Two, the person died unexpectedly while in an otherwise reasonable state of health. Three, the death occurred suddenly and during normal activity, so oftentimes that's sleep, like it was with my nephew. An obvious cause of death couldn't be found through an autopsy, and the death was not a result of status epilepticus, which you guys might know is just essentially a seizure that won't end on its own. So another question we get all the time, and I should say too, feel free to jump in and interrupt me with questions. We don't have to wait to the end, so just stop me at any time. What causes SUDEP? The short answer is we still don't really know. There's a lot of research that's going on. Obviously, there's three main theories that any of us could guess. It's involving the heart, the brain, or respiration. And it seems likely that it might be some combination of those. And it also seems likely that it might not be the same for everybody. So what caused it for Danny might not be what causes it for somebody else.
Excuse me, may I ask, did Danny have any of those issues?
He had seizures at night. And we'll talk in a minute about some of the major risk factors. And he did have a few of those.
But did he have a heart thing?
Oh no. And when I say that, I mean, what ultimately causes the death? Is it cardiac arrest, or is it, he didn't have any existing medical issues. Yeah. I mean, like what actually causes the death. So respiration, something to do with the heart. Is it cardiac arrest or is it brain failure? That's still being studied. Another question we get a lot is how often does it happen? This is a tricky question because one of the issues is a lot of medical examiners or coroners don't know what SUDEP is, and so the data collection is probably not what it could be. In other words, we think there's probably cases of SUDEP that are never described that way. So talking about the incidence is tricky. But what research has shown that we talk about is when the seizures are not controlled, it's about 1 in 150 people annually that will die from SUDEP, which is, to me, a really high number. It's frightening. If seizures are controlled by medication, that number changes to 1 in 1,000. So a big difference. So the takeaway for all of us being, that seizure control is really important. And, we know that seizure control is not reality for some people, for some families. So the idea then becomes as few seizures as possible, whatever that means, if it's a dozen down to, let's say, 2 a week, or if your family's experiencing dozens a day, maybe it's down to 10 a day. It's different for everybody, but the idea that fewer is better. So with children, it's believed that the incidence level is somewhat similar, 1 in 1,000, if the seizures are controlled. So the next thing we talk about in our risk factors, the biggest one I've already mentioned, and that's uncontrolled seizures. So the higher the volume, the higher the risk. Another big risk is tonic-clonic seizures at night, and that's what Danny had. So he didn't have a lot of seizures relative to other people, but he did have grand mal seizures in his sleep. So if we look at kind of a fuller list, seizures that can't be controlled, tonic-clonic seizures, a lack of treatment adherence. So if you're not taking your medication, it's believed that your risk goes up. Long-standing chronic epilepsy, seizures that happen during sleep, so Danny's case. Stopping the use of medications abruptly, as opposed to like weaning off of them. Developmental delays, and the onset of epilepsy at a young age. Those are all believed to be risk factors. So one thing we emphasize, it's important to talk to your doctor about your individual or tailored risk. There's this set of general risks, but we advocate for parents to talk about the individual specific to your child. That's really important. So now I'm going to pass it over to my colleague Mary Duffy, who is going to talk about some of the ways we think we can minimize the risks.
Hi everybody, thanks for coming today. I'm part of the organization because my son was Danny's best friend, and I'm Mary Ann, which is Danny's mom's best friend. So I'm going to continue what Tom was talking about here. You're introduced to the word SUDEP and the risk now, so we ask that you take a few steps to educate yourself by talking with your doctors, and again, what Tom mentioned, tailoring your treatment to the type of seizures that your child is having or you yourself are having. There's a couple of, one thing I should mention too is just that a couple of conversations at the table I had already this morning that's important to that doctors educate every family, so you might have to actually bring up the conversation to your doctor. And I say that because of what Tom said, that Danny only had 6 seizures in his life, so he might, to some people, be considered low risk and the subject might not be brought up. So it's important that all families are educated, and you might have to actually start that conversation. So next we're going to talk about maybe I went too fast. Sorry. A couple of things, and kind of touching upon what Tom already mentioned. But some things, first of all, is just making sure that you have the seizure control that you deserve and that you need, and that you partner with your doctor to get to that level. Things, just reminders from many of us, is making sure that you take your seizure medication consistently, in the right dose. Make sure you're seeing your epilepsy doctor and all healthcare providers regularly. It does sound simple, but we do hear, we didn't have a chance to go last time, or we skipped one. So just making sure that that's very important to you, and that it's on your calendar. Ensure that you or your loved one's getting enough sleep, limiting your alcohol intake, and avoiding any type of recreational drugs. Knowing yourself, knowing your triggers for your seizures, and doing everything you can to avoid that. Changing your lifestyle, changing your environment if need be. Keeping yourself healthy, stress-free as much as you possibly can as well. And then, of course, if medicines aren't working, speaking up and talking about with your doctor about different alternative treatments, maybe a dietary, a different diet, alternate therapies, or even surgery. If another step involving the family and friends too is ensure that family and friends and caregivers have knowledge on seizure first aid, as well as emergency resuscitation measures, defibrillators, and CPR. Okay. There's also a lot of ways you can track your seizures. There's a lot of applications out there right now, and diaries, making sure that you note all of that. It's hard to remember at that doctor appointment what happened over the last 3 months, so that you jot down the triggers, side effects of the medicine, just really knowing your seizures inside and out, so that you and your doctor can come up with a good plan to make changes, perhaps if necessary. And then lastly, there's something there's out there called devices that you can use to detect and actually alert you to a seizure. So that's the next slide here. So we like to call it another resource, another tool in your tool belt, to protect your loved one or protect yourself from any risks. A device, we should mention, doesn't replace a parent's instinct.
Any other questions regarding the epilepsy monitoring unit and the expectations for type of electrodes that may be used?
Was your son in for multiple days of the EEG?
Yeah, this last time he was supposed to sleep 24 hour, and then the EEG came back and he didn't have any seizures, and they didn't believe it, so they kept him another day.
Right.
And it was, actually they had treated the epileptic encephalopathy well enough that...
Perfect. And so that is one of the utilizations of an EEG to help guide the physician when they're interpreting. They may see something and then they add a medication, and then they would want to make sure that the waveforms that they saw earlier that were causing the seizures are now abolished based on the medication that was given, and that's exactly one of the main roles for an EEG. And it's having a technologist that's knowledgeable and to help provide your interpreting physician or epileptologist with that information.
The biggest challenge we have is he's had EEGs done at our regional medical center in Spokane, and then he goes to UCSF and they can't read what the other EEG that's been done, because it's a different system or something.
Correct. You are not alone.
And you can't just hit print.
Right. There are some options. There's third-party softwares, but the facilities need to have that to be able to interpret it. Hopefully, there is some type of interpretation, a report from a physician to help guide, even though you don't have the physical EEG itself.
Last time when he had epileptic encephalopathy, our regional center read the EEG one way, and San Francisco interpreted it a different way.
Yes.
That was super
So those are some of the differences and variabilities of education, knowledge, credentialing, board certified, and that's one of the things that we promote on a national level.
Zebras. San Francisco deals with zebras.
Very, very true. Very true. Good point. point. That's a very good point. You've done your homework and you've been researching, which is wonderful. And that's one of the things I think this venue is wonderful. It adds heightened awareness to what Brad is trying to do here to educate and make everyone knowledgeable of what opportunities are out there. And this is a wonderful venue for community and support. And you might discover there's things out here and you're not alone, right? And other people may be affected by it, and you can network that way. And I think this, or you might find another avenue that you didn't even know existed to help get treatment. Very true.
The other thing too is to take the information back to your physician and educate them, because sometimes they're in a bubble and they don't even know what's new and what's come across the pike. So sometimes that can really help as well.
Thank you for the information. What hospital do you go to?
Gritman Medical Center is in Moscow.
Yeah,
And then there's Pullman Regional Medical Center, and then there's
St. Joe's.
St. Joe's in Lewiston. That's
right.
about 45 minutes out.
Right. So it's having the capability of 24-hour support to be able to provide the service. And a lot of the larger centers have that. It's then when the smaller centers don't have that capability, what are the options for you? And so there's vendors, there's companies, they're all working together and getting that information to neurologists or epileptologists so they can better have resources and tools to help treat their patients. So that's very true.
Do you get to see your physician pretty much anytime you wish to? Your neurologist.
Our neurologist,
Well, your neurologist.
probably if we wanted to, but because they're in San Francisco and we're in Idaho, it takes a bit of.
Because we're finding that where we're at, there's only one neurologist at Children's Hospital. So it's, he's where is that? Fresno. Well,
Fresno.
Children's Hospital is actually it's Madera County.
Right.
But he's just, and I can understand why. He has so many patients. He's the only one there. So.
Right. There are some options for telehealth that's being rolled out, which I think is very helpful for patients and physicians to connect. If they're 6 hours away, what can you do to pre-screen or have that sort of one-on-one? And telehealth helps with that. So that's something you can probably maybe take back to your physician and see if that's an opportunity, especially if they're going to send you for a second opinion. Where can you go? If you're in Fresno and you want to reach out to one of the organizations or hospitals in the Bay Area, do they offer telehealth first to have that initial consult? It's a great venue here. It really is to get information. Ask everyone. I mean,
Is there like a how to read the screen cheat sheet?
So for
what?
You mean the EEG itself? If you go to our booth, I actually have an EEG scrolling, but the technologists, I can give you more information. Technologists, they should be trained. There's education, there's schools, right?
Well, I just want to know as a parent when I'm sitting in the room and I see stuff, I kind of want to know what.
That's an interesting concept.
I could simple things like eye blinks, muscle artifact.
I have that.
Yeah.
Okay.
It's a great.
And like a background, like there's normal background.
We don't. So that's one thing that we don't understand at all is the background. So he had poor organization, and then was upgraded to disorganization, and had periods of organization.
Right.
I tried googling those terms, and I got nothing. I'm like, what does that mean? What is organization? And why would he have periods of organization during sleep, and then no periods of organization awake? But he's walking and talking and what does organization mean? And I thought it was like when your brain is firing, like from point A to point B. Those are like if you can get to point B, then it's organized.
Well, and there's different brain waves that are normal for every age. So a newborn, as we can see with the newborn or a young baby, they don't have the motor skills, they can't talk. And obviously when you look at that, if you think about how their brain is developed, it's not as developed as your older son or us. So there's different levels of normal on the EEG. And so you kind of have to be educated from neonatal, pediatric, adult to all the normal backgrounds, organized backgrounds. And if they're not organized, then they have to decide what is different about this EEG. Let's go down that avenue, and they're trying to figure out how to diagnose it. So basically the EEG is an EKG of the brain. EKG, we all can look at that and tell it's a heart beating or it's a funny looking heartbeat. Well, there's a whole bunch of electrodes on the brain so it's a lot more in depth.
But what is organization?
Well, depending on how old was he at the time? 4. So maybe in the period of organization, that was maybe where it was more normal for his age. And then when it's disorganized, that would be maybe in the gray area. I don't know if he was having seizures at that time or staring spells or something like that they could relate any of his behaviors to the brainwaves. But usually the disorganization is not necessarily normal. There's certain patterns for pediatrics. Disorganization is normal. You expect that at certain ages. Like if they do deep breathing, if they have them do the hyperventilation as they get older, that will change the background, and it's called an activation procedure. The reason they do that is, unfortunately, to bring out abnormalities because you want to see that on the EEG when you're recording it. Photic stimulation, the flashing light, that's another activation. One of the main activations is sleep. So if you go in for 20 minutes, you're really not going to get into a deep stage of sleep, and that's why people do the 24-hour ambulatories or in the hospital extended EEGs, because sleep a lot of times will show the abnormalities where the patient could be awake all day long and you never see an abnormality. But as soon as they go to sleep, in and out of the stages, you see it over and over again. So, you ask, why does my kid have to be monitored for 3 days? The first day might not be enough. They might catch it on the third day.
So there's actually a lot of causes about why you can have epilepsy too. When I say post-injury, it's usually a severe injury, like a car accident. Most times you don't have epilepsy post-traumatic after like a regular concussion. These are usually severe injuries. In metabolic, a lot of times you can figure that out through genetic testing too, but there are certain metabolic tests as well. Okay. In structural, I didn't mention there's also a MEG scan. Anybody ever hear of the MEG scan? No. So that's another tool that's helpful when doing looking for epilepsy surgery options. They look at the magnetic waves, and it helps pinpoint where you suspect where the seizures are coming from. Okay. I know UCSF has a MEG scanner. I think San Diego does. At UCLA, we don't have a scanner, but we send our patients to UCSF. They do a MEG scan, and then we get the results. Okay. So that's also an option. Now, for other reasons why, other testing that we do, the main one is the EEG. Just because the EEG can show you where you suspect seizures are coming from. Is it from one spot versus the whole brain? Some EEG patterns have a very typical pattern, like Epson seizures have a classic 3 Hz spike wave pattern that makes you suspicious for that. Benign Rolandic epilepsy has another pattern that makes you suspicious for it. So based on the history as well as the EEG, you kind of have a good idea about what kind of seizures you might be having. Okay. What questions do you guys have about anything on this board? Please.
We have a neurologist and a neurosurgeon.
Sure.
But we don't have a you. Like, why would, what's the value? I know but why would we go get another doctor?
Yeah, so it depends on your neurologist if they're comfortable with epilepsy. So some neurologists have specialties in different options. So some neurologists do autism, some do neuromuscular, like muscular dystrophy and that kind of neurology. Some specialize just in stroke or other kind of things that fall within neurology. I think epileptologists, my training was in reading EEGs and working just kids up with epilepsy. That's kind of what all I do. So that's kind of.
So at what point would you go? We have an epileptologist.
Yeah.
And we were just given an epileptologist. So, but at what point would you usually move from a neurologist to an epileptologist?
If the seizure seizures are very difficult to control. If you're at a point where you've tried 2 medications and you're definitely